Please visit the booths, the people that are supporting this, and thank people like Julie and all of us that are working hard. We need your support, and you need our help. Let's work together. Together, we have a real good possibility of conquering this disease, and as I said, making it a thing of the past, hopefully like polio someday. So I'm going to end here. There's much more to be said, but that's somebody else's problem today. So it's a pleasure to be here. I can't tell you how heartwarming it is to see you all here. And I look forward to having an opportunity to talk to you and answer your questions later. Thank you very much. So do we introduce the next speaker? I actually don't know. I don't have the... Julie, who is the next speaker? Okay, I'm going to present Dr. Murman then. Dr. Murman is our former chairman of the Department of Neurology at University of Nebraska, and he is someone that also has Michigan roots, so that's a good thing. And he's going to be talking today on dementia and psychosis, the problems in the worsening of Parkinson's disease. Let's welcome Dr. Dan Murman.
Thank you, John. I am so impressed by so many people here, and it's a tribute to the organizers and to your interest in the community. So my topic's a little bit different, but we're going to talk a little bit about sort of the mental, cognitive aspects, and some of the psychiatric aspects that happen with Parkinson's disease. Let me see if I can get my first slide. So we're going to kind of go through a quick overview of what kind of thinking changes happen. So for a long, long time, we thought of Parkinson's disease really just as a condition that caused tremor, slowness, stiffness, but we now know it can affect thinking, and we'll talk about that in detail. We'll talk a little bit about how physicians would kind of put you into categories, whether you have mild cognitive impairment, dementia, is your cognition normal, or a different condition that's related called Lewy body dementia or dementia with Lewy bodies. We'll talk about some of the treatment options for the memory part, the thinking parts. Next, at the end, we'll talk about psychiatric symptoms. There's a whole range of psychiatric things that can happen in Parkinson's disease, and we'll talk about some of the treatments. Let me see if I can go backwards a second. All right, very good. So the original description by James Parkinson's was observational. So he looked at a series of patients that had stooped posture, they had short steps, they had a tremor on one side with walking. And his description in detail of some of the movement parts of Parkinson's disease eventually was attributed to his name and what we call Parkinson's disease. But at the very end of his essay, he mentions that the intellect is unimpaired. And that, we think now, applies, many patients do have intellect thinking changes that happen with Parkinson's disease. So it was in the 80s that neuropsychologists summarized the kind of thinking changes. If you took a group of Parkinson's disease, as Dr. Bertoni said, everybody's different, but on average, these were the type of thinking changes that people had. And we'll go through those in a little bit of detail, but much like there's a slowness of movement that we call bradykinesia, there's a slowness of thinking. Processing speed is slower. There are changes in what we call executive function, which I'll explain. There's changes in memory. There's changes in vision, visual spatial processing and perception. And then one of the hallmarks of thinking changes in Parkinson's disease, it's very variable. It changes one time of the day versus later in the day, one day to the next. So just to kind of show you pictorial representation. So this slowness of thinking is something to be aware of. So you need to have more patience with yourself or with a loved one that has Parkinson's disease, because typically the answer is there. It just may take longer to process, longer to come up with the answer. There's a slowness of thinking. This executive cognitive function is a concept, much like a boss or a CEO of a company has a lot of different responsibilities. And this is sort of the part of the brain that does things like decision making. And the other aspect is things like problem solving, delegating, multitasking, sequencing, planning. So that's the part that can be less efficient, harder to make a decision. This picture on the right would be if you were faced with a bag of Legos that were all taken apart, trying to figure out, okay, how are we gonna put this together into a meaningful type of a product at the end. So you gotta kind of plan, sequence, figure out how to prioritize what you're gonna do. So this aspect of thinking, planning, decision-making, processing can be affected. There is a memory change in Parkinson's disease. It is different than in Alzheimer's disease. One of the main problems in Parkinson's disease is retrieving information that you do know. So it's in there, you just can't get it out when somebody asks you. And there is a trick that cueing, giving somebody a clue, whether it's a category or multiple choice, is helpful because they really know the answer, they just can't think of it at the moment. And learning new things is still relatively preserved. And I think that's a distinction with Alzheimer's where a lot of times that new learning is the problem. It never really gets into the memory stores. But in Parkinson's disease, new learning is still relatively intact. It's just getting information out sort of when asked on the spot. These are just kind of pictorial representation of the visual spatial processing, visual spatial perception problems. So the upper left would be asking somebody to draw a clock and put the hands on the clock so it says 10 past 11. But then on the rest of the clocks are people struggling with sort of what that would look like and where to place the hands. So putting things together in a visual way. But in Parkinson's disease, it sometimes shows up by struggling with reading. The lines may be hard to track a line. It may be hard to put something back together because you can't quite understand how things fit together in your mind with your visual spatial abilities. And this is just trying to bring home this point that fluctuations are kind of the hallmark. So people commonly with Parkinson's disease may have a certain time of day where they're quite sharp and a different time of the day where they're not as sharp. And that's typical of all of us when we're tired, but more pronounced in Parkinson's disease, that thinking, processing just isn't working as good toward the end of the day often. So let's go through sort of when physicians try to categorize you. So we initially make a diagnosis of Parkinson's disease, and John mentioned the kind of the hallmarks. So there's a tremor, usually a tremor at rest, often just on one side of the body. There's slowness of movement, we call bradykinesia. There's a stiffness we can feel called rigidity. And there's changes in walking, shorter steps, stooped posture, and eventually loss of balance. So those would be what we would make a diagnosis of Parkinson's disease. It's still a clinical diagnosis made in the clinic based upon your examination and your story. But to kind of label somebody as having maybe some thinking problems associated with the Parkinson's, we first make the Parkinson's diagnosis, and then we ask for any symptoms of potential change in thinking. So usually patients, and if not the patient, also the family, will have noticed some changes in thinking. So there need to be some symptoms that, yeah, there's been some thinking changes in somebody that has a Parkinson's diagnosis. And then we will try to measure it, either in the office with sort of a bedside office-based memory test, or neuropsychological testing, which would be much more thorough and in-depth testing of thinking, to see are there some changes that we can measure when we try to compare your score to a control group. And one of the distinctions between what we call mild cognitive impairment, which is a category, and the term dementia is whether it affects your everyday function. So in mild cognitive impairment, people are still fully independent in driving, doing their taxes, and doing their everyday activities that they've done their whole life. As things potentially get worse and the thinking problems get more severe, then if we move into what we would label as dementia, then there would be some difficulties doing everyday activities. And often the more complicated activities, like more complex financial things, driving, things like that might be affected where it's not as safe because there's been thinking changes that might affect it. So this kind of leads into this dementia. So again, to make a diagnosis of Parkinson's disease with dementia, you have to have a Parkinson's disease clinical diagnosis. And then we have this rule that in classic Parkinson's disease, for patients that eventually develop mild cognitive impairment or dementia, it's the movement problem first. The movement problem lasts at least a year and often 5, 10 years before we might see some thinking problems. And that 1-year rule is to kind of distinguish it from this next condition called dementia with Lewy bodies. So in Parkinson's disease with dementia, movement problems predominant for a long time, typically years, and then later there might be some thinking changes. And eventually, if it progresses dementia, we call it Parkinson's disease with dementia. And for all these conditions, we want to make sure there's not some other cause, so that dementia not due to another condition. But when we're trying to diagnose this Parkinson's disease with dementia, we kind of expect those classic types of thinking problems to be present in somebody with a Parkinson's disease diagnosis, and it's bad enough to interfere with the everyday activities, then that would be PDD. So the Lewy body dementia condition, dementia with Lewy bodies, said both ways, DLB, is a very related condition, but think of this as starting with the thinking problems and then later having some movement problems. So this would be somebody that has either cognitive or psychiatric symptoms first and then may have some Parkinson's features, but not the other way around. But this sort of starts in the thinking parts of the brain first, and then later these automatic pilot deeper structures of the brain. These patients often have a lot of psychiatric symptoms like hallucinations. They do fluctuate a lot, and then have some of the thinking changes similar to Parkinson's with dementia. So those are sort of the categories. If you have a Parkinson's diagnosis, we may determine that your thinking is normal. You're thinking maybe this mild cognitive impairment, you might have signs of dementia. So this is just a slide of, if you took a movement disorder clinic, say had 6,000 patients like the clinic at Nebraska Medicine, what's the percentage that might fall into these categories? So on this slide, about 43% in this study is kind of a consensus of several studies. About 43% had normal cognition. So they had Parkinson's disease as a diagnosis. Their thinking was fine. About 27% had this mild change, and then about 30% had Parkinson's with dementia. So it gives you a sense. It's common, certainly, to have cognitive changes. So nearly 50%, well, 57% had some thinking changes in kind of a typical Parkinson's clinic. The other thing to be aware of, the risk of getting memory and thinking problems increases over time. So this is called a survival curve, and if you go to the far left of this graph, at the beginning, everybody has Parkinson's, but not memory problems or cognitive problems. And then this slide actually is people that would be called Parkinson's with dementia. So after 5 years, about 19% had transitioned from having normal thinking to now they would have Parkinson's with dementia. And after 10 years, 38%. So it's something that is more likely to happen the longer you have Parkinson's disease over time. These are a series of risk factors that sort of also point to who's at a little higher risk to have thinking problems with Parkinson's disease. So it tends to be, if you develop your Parkinson's disease at an older age, a little higher risk of getting memory problems. The more severe your movement symptoms, motor symptoms, and the longer you've had Parkinson's disease, those two are kind of related. As the disease has progressed longer, we see more trouble with memory and thinking. If you've never had a great response to the medications that are often used, like carbidopa, levodopa, that makes it a little more likely to have memory and thinking problems. And some of the other non-motor symptoms, like acting out of dreams, changes in your blood pressure when you stand up, can sometimes be more common in people that have memory problems. So there's a couple slides about sort of what's the underpinning, what do we think causes the thinking problems. And the thing to think about is kind of those subcortical, below the surface, things that are involved in the movement of Parkinson's disease. So on the left-hand side, a brain structure called the substantia nigra shows what's called a Lewy body. So Lewy was a person, a neuropathologist. He described this inclusion, this kind of round inclusion of protein when he looked at the slides of the brain as somebody with Parkinson's disease. And that correlates well with things like tremor, stiffness, slowness, the gait changes. On the right-hand side, a little harder to see, but made up of the same components, are these Lewy bodies in the thinking part of the brain, the outer surface part of the brain. So we really think these Lewy bodies, the pathologic changes of Parkinson's disease, when they move into the thinking part of the brain, the cortex, or the emotional part of the brain, then we get some of the cognitive and psychiatric symptoms. So, small slide. If you look on the right-hand side of that picture, it says basal ganglia. So these are all these deep structures that really are the things that correlate with the movement problems. But when we move into the surface of the brain, areas called the temporal lobe are involved in memory. The parietal lobe is on language and visual spatial processing, and then the front part of the brain, the frontal lobe, in decision-making, executive cognitive function. When those get involved, then we're going to have cognitive issues. And on the bottom slide are some structures called the limbic system, or some of these structures are part of the limbic system, which are the emotional part of the brain. And when they get involved, we're going to have more psychiatric symptoms. So this on the left is a stain of the protein that makes up the Lewy bodies, which is called alpha-synuclein. So it goes from stage 3 up to stage 6. So each stage would be sort of more and more of the pathologic changes of Parkinson's disease moving into the thinking part of the brain and the emotional part of the brain, which would correlate with some of these symptoms. So it is sort of a different stage of Parkinson's disease as the disease has kind of progressed to new parts of the brain. So just want to go through a couple of slides of kind of how we approach somebody with Parkinson's disease. It says, you know, my memory is not as good as it used to be. I'm kind of fluctuating with my thinking. So initially, as Dr. Bertoni mentioned, we want to make sure there's not something else that's treatable, like vitamin deficiencies. Sometimes there's an imbalance of hormones, like thyroid hormones. Sometimes other medical conditions are affecting your thinking, and many of those are treatable. We want to make sure you don't have a treatable sleep disorder. Sleep is vital for memory and for cognition. If you don't get good sleep for whatever reason, you won't be as sharp the next day. So we look for signs of treatable sleep disorders that we can treat. We'll screen for symptoms of depression, anxiety. Those are treatable and can help cognition secondarily. We review medications really trying to figure out, are there things that people shouldn't be on that are making things worse? So yes, they have Parkinson's, but your medicines are making your thinking worse. Usually we'll do some type of testing of thinking. We need to kind of establish, just like you do a blood pressure, to see if somebody has high blood pressure. We have to kind of measure your thinking. And brain imaging would be indicated if we're trying to rule out things like stroke or other things that might be affecting thinking over and above or separate from Parkinson's disease. There are medications that we as physicians kind of watch that we want to make sure you're not on or try to minimize that. One class of medicines blocks a brain chemical neurotransmitter called acetylcholine, and those make you less efficient, less sharp mentally. So it's a catch-22. A lot of patients with Parkinson's disease have some bladder control issues, but some of the bladder control medicines can make you a little less sharp with memory. Some people use over-the-counter Benadryl as a sleep aid, like Tylenol PM, just because they have sleep issues, but the Benadryl part of that can make you a little less sharp, especially at night and the following morning. People can have chronic pain with Parkinson's, and we have to just make sure that their pain medicines aren't making things worse. And some of these medicines used for anxiety or sleep, we just have to be careful that they're not making things worse. So it's a balancing act. There are, many symptoms we're trying to address, but we want to make sure you're not on medicines actually making your thinking worse. So when it comes to treating memory and thinking problems, the hallmark really is, just like the movement part, we need you to be mentally active. You need to keep your brain engaged. You need to exercise your brain. And we think physical activity that you would be doing for Parkinson's disease helps you mentally also. So those are key things that you can do, trying to keep mentally and physically active. We also think from a kind of emotional standpoint and psychiatric standpoint, we need to keep you socially connected with friends and family and to remain social. And it isn't stated on the slide, but we need to also make sure that there isn't too much stress. So find ways to try to address stress reduction can be helpful from a mental standpoint, both thinking and psychiatrically. There's debates about what's the healthiest diet, but there's clearly aspects of diet which are not ideal. So you'll hear about that this afternoon. So these are kind of common sense approaches, but make a big difference. Keep mentally and physically active, have a healthy diet, keep kind of well-connected socially with friends and family. There are prescription medications that can help. They're not a cure, but they do help with kind of focus or attention. They do help with short-term memory, and they can be beneficial. They can sometimes even help with apathy that can happen. So I wrote down the brand names and the generic names. So this is always the case that there's a brand name and a generic. So the generic names are listed there, but you probably know the brand names better, like Exelon, Aricept, and Razodine. We think that they're very similar and they appear to be equally effective, but this class of medicines can be helpful. But there's always a downside of prescription medication, so some people get a little worse tremor with these medicines used for memory to boost your memory. You certainly can get nausea or lack of appetite, and loose stools or diarrhea can be a complication too. Some seem to kind of make vivid dreams, not necessarily nightmare, but vivid dreams more common. Rarely things like muscle cramps and increased risk of fainting. So it's just like the TV commercials. By the time they get down of all the bad things that could happen, you're not too excited about taking it. But on balance, they can help with memory and attention, and if we kind of monitor you closely, we can avoid side effects or stop the medicine if it's giving you trouble. This is just kind of a slide of rivastigmine, which is FDA approved for treating Parkinson's patients with dementia, of kind of the improvement. So the upper graph there, as you go above the baseline there, those people are doing better on rivastigmine on a memory test. And the bottom is just a rating, so the examiner doesn't know if they're on the drug or not, and sort of rating, are they the same, a little bit worse, a little bit better? And it kind of shifts. The darker bars are the people on the drug. It has sort of shifted the curve where more people are doing a little bit better and less people are doing a little bit worse on these medications from a global standpoint. So I wanted to end today and talk a little bit about the psychiatric symptoms. As you can tell from the slide, there's a lot of potential psychiatric symptoms that can happen. And we'll go through each a little bit, but depression, apathy, anxiety, psychosis, which would be things like visual hallucinations or delusion, like thinking somebody's in your house when they're not. And then impulse control is kind of a newly recognized problem that can happen in Parkinson's disease patients that I'll mention. Depression is common. It can start really early in the disease process and can extend throughout the whole disease process. There's certainly, so typical symptoms would be, lack of enjoyment of things you used to enjoy, sadness, loss of hope, crying, and sometimes more irritability. Frustration, of course, but sometimes irritability. Those can be symptoms of depression. So people that have more severe Parkinson's tend to have some more depression, certainly later in the disease. And we really think the changes in brain chemicals that happen in Parkinson's disease, we talked about dopamine and how that's so important for movement and actually motivation. But other brain chemicals are affected in Parkinson's disease. So things like serotonin is very closely related to depression and anxiety. So much of this is biologic, brain-driven. Certainly, it can be discouraging to not be as mobile as you used to be and have more difficulty, and that can be part of it, but often it's also kind of changes in the brain that are making it more likely to have symptoms of depression. So there certainly are medications that can be effective, and then we also rely on non-medication approaches. So some can be cognitive behavioral therapy, which would be sort of like a psychotherapy, talk therapy, even exercise and keeping physically active can help on depression and anxiety. Improving sleep can help. But there are medications definitely if depression becomes moderate or severe. Apathy is quite common, and sometimes we often, when somebody doesn't have motivation to do something, they say, well, they're depressed, but they don't always run together. So you can have really this lack of get up and go without being sad, tearful, and hopeless. So apathy, again, brain-driven. There are common in Parkinson's disease, and just something we need to watch for. And we're the ones that have to kind of separate, well, is this depression or is this kind of a separate condition? And this can happen real early in the disease. And so there are some different medications to consider, and including this rivastigmine, which we're using for improved memory, might also help a little bit with apathy. Anxiety, real common. Up to 60% of patients with Parkinson's will get a nervousness, an excessive worrying, and fearfulness, afraid something bad's going to happen. So this is real common, and a little more common in younger patients, women, and when people move from Parkinson's disease that's well controlled with medicines to having a lot of fluctuations, the on and off phenomenon or dyskinesias, that's often when we can see more anxiety symptoms. And sometimes the anxiety is triggered by the medicines wearing off, so the end of dose kind of off feeling sometimes drives a lot of nervousness and anxiety. So the approach can be to adjust your Parkinson's medicine if it's related to these ups and downs of your medications and a fluctuation in your Parkinson's disease. But alternatively, a lot of the medicines, they're called SSRIs, which are used for depression and anxiety. They are effective for helping with anxiety. So impulse control, this is up to 35%. That's probably a little bit high. I think significant problems in impulse control, probably more like 10%. But there are some patients who have never had trouble with things like gambling, that as they get Parkinson's disease and as they're treated, all of a sudden they kind of can't stop gambling. They might have enjoyed it a little bit, but now it's an obsession and can cause some real problems. So dopamine is very much involved in the reward system. The medicines we use drive dopamine so you can move better, but sometimes when that system is driven too much, people are kind of driven to kind of get that reward that you might get from gambling. Sometimes it's shopping, sometimes it's eating, certainly could be alcohol and sexual behavior. So just something to be aware of that can be very much involved in the disease process. So younger age can have this problem, and a class of medicines called dopamine agonists are a little more likely to trigger this kind of negative side effects. So something we need to be aware of. If you've had addiction problems, you may have sort of a setup to be more prone to this. So we sometimes try to lower or stop the agonist and or other Parkinson's medicines sometimes can decrease the problem here. Finally, the psychosis in Parkinson's disease is this problem that happens where patients begin to see things that aren't there. It may start off by just thinking somebody's next to you and you look and they're not there, but eventually it may be seeing a person or an animal. Typically what's seen doesn't make any noise. They don't speak or talk or bark or things like that. Often early, patients know that they're not real, but they're very repetitive, and they may look out the window and think that there's a crowd of people or other things like that. It can also involve hearing things. It can also be more of not that you actually saw, but you think somebody's in your home that's not there, like somebody's coming over for dinner, things like that, or you might think that they're there. So as you get a little bit of memory loss, this happens more commonly. Some of the medicines can make it more likely, so that's something we would review. And often adjusting the Parkinson's meds is the first approach. There is a drug now called pimavanserin that has been approved by the FDA to treat this psychosis in Parkinson's disease. And this is kind of a picture where the people on the drug are on the bottom, so they had a decrease in hallucinations on this drug, this Nuplazid drug. So it is the only drug approved for psychosis and PD. So this final slide just shows above the line are the movement changes. The circle there, this is tiny, I know, is the classic kind of tremor, stiffness, and slowness. That's at the early stage. Mid-stage would be these fluctuations, and late-stage swallowing problems and falls. On the bottom are this whole series of non-motor symptoms that are getting more and more attention. So we've often focused on the movement problem, but there's quite a few non-movement problems that are problematic, and Dr. Seier will talk about more non-motor symptoms after me. So below the line, these two, we talked about mild cognitive impairment. So at the end of the kind of early stage, it wouldn't be uncommon that people might have some subtle thinking problem, but they're still independent. And as we get to more late stages of Parkinson's disease, it might transition into more of a dementia. Below that, these circles that came in, depression and anxiety can happen real early, but honestly, they can continue throughout the disease. In the middle is kind of apathy, this lack of get up and go that often is very much disease-driven. And then finally, as we go between mid-stage and late stage is when we might start to see some hallucinations and delusions that I mentioned at the end. All right, I think that's all I got.
Thank you, Dr. Murman. That was very enlightening. Our next speaker is Dr. Mara Seier. She is an assistant professor in the Department of Neurological Sciences. She is our newest and youngest addition to the movement disorder team. I wish I could tell a story on each speaker here, but we'd be here all day. But anyway, Mara is an absolute delight and a wonderful addition to our team, and she is going to speak today on non-motor symptoms.
Thanks, Julie. So, like Julie said, my name is Mara Seier. I'm one of the Parkinson's movement disorder specialists at UNMC, and I've been here about 2 years. So what I'm going to talk to you today about, if we can get the talk up, is a couple of non-motor symptoms, including difficulties with sleep, dizziness, and drooling. And I like this analogy of Parkinson's disease as an iceberg, because above the surface are a lot of the motor symptoms, the things that we can easily identify from other physicians or other people that you meet. And these are the things that are very visible. So the slowed movements, the tremor, the stiffness, and the changes in the walking. But if you don't take a deeper look, or people that you just are meeting on the street, and even your other doctors, they may not really realize kind of what's underneath the surface and the magnitude of the other issues that people with Parkinson's struggle with. And that's what we call the non-motor symptoms. And we heard a bit about those from Dr. Murman. He talked about the depression, anxiety, hallucinations, the memory issues. But these also encompass things that our autonomic system, our kind of autopilot, does. And so things like urinary problems and bowel problems like constipation and sexual dysfunction, and then as well as dizziness, which I'm going to be talking about today. So those things are controlled by our nervous system and are things that we don't have to think about, but can be affected in Parkinson's disease. Pain, fatigue, difficulties with swallowing, and then drooling and sleep disturbances are some of the other non-motor symptoms. So we'll just be focusing on 3 today. There are certainly room for other discussions on other of these topics, but they are each and of their own a whole talk. So we'll be talking about dizziness initially here. So this is a very common issue that people come into clinic with, is feeling dizzy or lightheaded. And most often, that in Parkinson's, this is due to a drop in blood pressure. So basically, the brain likes to be filled with blood because we're getting oxygen and all the nutrients. And when there's a decrease in the blood pressure, less of that is occurring, and it can cause dizziness. The term that you'll read about or will discuss in clinic is orthostatic hypotension, or sometimes called postural hypotension. And those are just terms that we mean when you change positions, so especially from laying to standing or sitting to standing, when there's a change in position, there is a drop in blood pressure. And that's what that hypotension is just a low blood pressure. So I'll be referring to it mostly as orthostatic hypotension from now on. So besides dizziness, orthostatic hypotension can also cause a number of other symptoms that you may not realize are actually linked to the low blood pressure. So at the extreme end is actually having falls or passing out. So the brain is actually signaling to you that I need more blood flow. I'm going to make you lay flat until that happens. And so that is a more extreme symptom. But